Good evening and welcome to tonight's clinical seminar from the Children's Mental Health Resource Center. Can kids have bipolar? Bipolar disorder in children ages 5 to 15. For those of you who are unfamiliar with our organization, we are a 501c3 nonprofit. My name is Elizabeth Errico. I am the executive director. And with me tonight is our clinical director, Jennifer Sevick. She is going to be managing the Q&A panel for me during the presentation, and then after the presentation she is going to lead a live Q&A where we will take the time to answer any questions that you have. If you are watching this as part of a recording, I want to let you know that we will not be recording the Q&A. That during that time, many people share personal things. And so if you would like to participate in our Q&A sessions, please make sure to attend our live events so that you can hear the questions that are asked and the answers that are provided. As I mentioned, we are a 501c3 nonprofit, and our mission is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype that's referred to as fear of harm, or FOH. The current name for this diagnosis is thermoregulatory sleep dysregulation disorder, but that's a mouthful. And so we stick with FOH to make it simple. In order to fulfill this mission, we provide a number of programs and services that empower families to be able to navigate the mental health care system more easily, to have a support around them as they do so, and to give them tools that they can use right now immediately to help alleviate their child's symptoms and to improve quality of life. These programs and services include our palliative parenting class, which is available as a face-to-face course with the next round of that course beginning in April. We also have an on-demand self-guided video course in palliative parenting that contains all of the same information and resources available for the face-to-face course, but it is available to you anytime at your convenience to complete at your own pace. We also have our ketogenic therapy and action program, which is currently a research study examining the use of ketogenic therapy in the treatment of bipolar disorder in children ages 6 to 17. That will be launching into a broader program for folks of all ages with bipolar and kids with any diagnosis later this year. So stay tuned. We also have our software called the CMHRC Toolkit, which includes the ability to track medication, symptoms, mood, the weather. It can hold the history of medication trials and diagnoses that have been given and then rescinded. It's an invaluable tool for keeping track of how your child is doing and being able to match what symptoms are present with the medications. This is also a really valuable tool for providers and practitioners, and we'll get into that a little more later as we explain how you can use this tool in order to keep track of your clients and patients when they are not in your office. We also have our high-touch personalized support services for providers and families, the Wayfinder services that include our diagnostic support, our community advocacy consultation, and our interdisciplinary professional discussion groups, which we'll also share more about because the next round is beginning again in April. We are a nonprofit, and so all of our services and programs that have a fee are kept at below market rates in order to ensure that as many people as possible can take advantage of them. Uh, those things are limited, however, and most of what we do is free of charge. In order to be able to fulfill our mission and provide these free services and these subsidized services, we rely on the generosity of our community. So if you have enjoyed some of our free services, if you have benefited from some of what we have to offer, we ask you to consider making a gift to support our work. it is 2025, and our campaign this year is Give 25 in 25, either through a one-time gift or, more helpfully, setting up a monthly recurring donation of $25 a month to help ensure that all families have access to the support services that we offer. Okay, so before we start and we dig in here on our learning objectives for tonight, we want to start out with some, to pre-address, if you will, some concerns that folks have every time we run this seminar and similar ones. Because there are a lot of people out there who think that kids can't have bipolar, cannot be diagnosed with bipolar. And so to address some of those objections up front, we want to share with you that what we're not saying here. So we are not saying that all kids with mental health issues have bipolar disorder. We recognize that there are many other diagnoses that can be diagnosed accurately, and some kids don't have mental health illness at all. Some kids just have their own issues going on that don't deserve to be labeled as bipolar disorder. So we're definitely not saying that. We're also not saying that all kids with behavior problems have bipolar disorder. We're also not saying that other diagnoses don't exist. For example, ADHD, PDA, post-traumatic stress disorder, borderline personality disorder. These are all diagnoses that exist, that we recognize, and it's important for us to be able to differentiate from bipolar. We also are not saying that all kids need to be on medications. And that is something that we hear a lot, that we are advocating for parents to drug their children. Absolutely not. We are advocating for the judicious use of medication when appropriate to treat symptoms that are unrelenting. Okay, so now what are we saying? We are saying that a differential diagnosis is a part of ethical and competent mental health care, just as it is with physical health care. We're also saying that without knowing what bipolar disorder looks like in children, because the symptoms differ in presentation from that in the adult manifestation, you as a provider cannot do a complete and accurate differential diagnosis. We're also saying that until you are able to consider, examine, and know what bipolar disorder looks like, you can't confidently rule it in or rule it out as a diagnosis, and that it must be considered. So with that in mind, we can also recognize that sometimes medication can help with bipolar disorder, and when it is used judiciously and carefully, it can make a tremendous difference in those unrelenting and devastating symptoms. So with that said, on to our learning objectives for this evening. And they are to understand what bipolar disorder is and what some of the unique challenges to diagnosing pediatric onset bipolar disorder are, to recognize the symptoms of bipolar and how pediatric onset may look different from late adolescent or adult onset, to learn about recommended steps to diagnosing and proven assessments for pediatric onset bipolar disorder, and to understand effective treatment interventions. So as clinicians, we have often been taught that we may only encounter 1 or 2 children in our entire career who live with bipolar disorder, or that bipolar disorder even cannot exist in young children. But for decades, the literature in peer-reviewed journals published as recently as 2024 and going back 30 to 40 years unequivocally supports the notion that bipolar can be diagnosed in childhood. In fact, research sponsored by the National Institutes of Mental Health and others reveals to us that an astonishing 50% of mental illness begins before the age of 14, and that bipolar disorder affects nearly 3% of all children, 7% of children receiving outpatient psychiatric care, And the numbers are even higher for children who have been hospitalized inpatient with the need for psychiatric care. And that 1/3 of the 3.4 million children and adolescents who are diagnosed with depression in the United States may actually be misdiagnosed and have early onset bipolar disorder. So yes, bipolar disorder can exist. It is not a unicorn illness. And within the academic and research communities, there is a consensus that childhood onset bipolar disorder exists, is not uncommon, and manifests differently from its adult counterpart. While this perspective may be unfamiliar to many practitioners, it's not really that hard to accept and to understand when we talk about what bipolar disorder is and what it's not. And one thing that is absolutely clear is that when we're talking about bipolar disorder, we are not just talking about a set of symptoms that are manifesting in some sort of abstract place like the mind or the psyche, but rather that bipolar disorder is in fact a biological illness of the brain. Prior to the publication of the fourth edition of the DSM, which came out in the very early 2000s, bipolar disorder was known as manic depressive disorder. And it was characterized by having these mood swings of intense highs and intense lows. But thanks to ongoing research, we now know that at its root, bipolar disorder is based in a neurological condition that causes intense shifts in emotional states that can last days, weeks, sometimes months, and we call these mood episodes. Current research, again, research that is literally happening right now all across the world and currently at CMHRC, is beginning to conceptualize bipolar disorder as an energy disorder in which the person has either too little energy, which results in depressive episodes, or too much energy, which results in manic episodes or hypomanic episodes. And that energy shift impacts the way that an individual is able to function. Harvard psychiatrist Dr. Chris Palmer has developed a cohesive theory characterizing mental illnesses as rooted in mitochondrial disorders. And decades of scientific evidence, including research by Dr. Ian Campbell at the University of Edinburgh, suggests that mental illness is rooted in a systemic metabolic dysfunction that affects the brain. If you'd like more information on these current conceptualizations of bipolar disorder, you can look at the website of a group called Metabolic Mind, which brings together experts from all over the world, as well as those who have the lived experience of bipolar disorder, to talk with those who are studying this disorder, talk with those who are living with it, and to examine the metabolic causes of bipolar disorder and its treatments. As I mentioned, CMHRC is currently engaged in research on this metabolic dysfunction and the use of metabolic therapies in order to treat bipolar disorder. We hope to be publishing our findings early next year. So again, be on the lookout for that new information as it comes. So if we're going to accept this premise that current research is pointing us to, that bipolar disorder is about neurology, it's about energy, it's about mitochondria, it's about metabolism, then there is literally no reason why bipolar disorder cannot exist in children. The trick is knowing how to identify it and to differentiate it from other disorders. So now we do get a lot of pushback on this, so I want to again acknowledge a couple of things up front. Some providers and clinicians will say that even if bipolar disorder can be present in childhood, it doesn't mean that it should be diagnosed in childhood. They say that it's too serious of a diagnosis, and that developmentally normal phases or developmentally expected phases or even trauma can mimic the symptoms of bipolar disorder, and that it's better to wait and to not diagnose until late adolescence or mid-adolescence at the earliest. But when we consider the fact that we know that 50% of mental illness begins before age 14, and that the treatment onset delay between when a parent recognizes their child needs support and they receive an accurate diagnosis and effective treatment averages 10 years, we have to consider the possibility that refusing to consider, to rule in, or to rule out bipolar disorder in children under the age of 14 can result in a massive treatment delay. 10 years is a childhood lost, plain and simple. It's devastating to consider the future physical and mental health implications in adulthood if we do not use the number one best tool that we have in promoting positive outcomes throughout the lifespan, which is early identification and early intervention. When managed properly, when effective treatment is given, people who are living with bipolar disorder can not only survive, but thrive. It is a manageable illness when we know what the symptoms are, what they look like, and how to treat them. So, what do we need to do correctly so that we are not over or under diagnosing bipolar disorder in kids and teens? Well, for starters, we have to look at the DSM. This is the tool that we are given as clinicians to assist us in the diagnostic process. For any laymen who are here, the DSM is the Diagnostic and Statistical Manual of Mental Disorders. It is considered the Bible of the mental health care field, and providers use it to determine diagnoses. It took its modern form in 1980 when it was revised into the third edition of the DSM. And that revision include categorizations of disorder names and lists of symptoms that went along with each of these disorders. And this revision was based on decades. I shouldn't say it's based on. This revision was conducted because for decades there was wild variability in diagnosing from one provider to another. And if you're interested in learning more about the history of the DSM and how it can really fail providers and their patients, I recommend that you check out one of our previous clinical seminars, which is on our YouTube channel. And so that you can get a deeper dive into this. You can also read about the Rosenhan experiments, which we talk about in there, which for clinicians will be truly fascinating. But I digress. The DSM was restructured in 1980 so that it could provide a shared language for providers to be able to talk with one another about the disorders that they were seeing. In practice, it was to fundamentally ensure that professionals all across disciplines, across geography, across areas of practice and educational background would be able to effectively communicate with one another and have a uniform understanding of what the specific disorders that they were treating were. And so this means that when we use the term major depression or post-traumatic stress disorder, there's a standard definition based on a specific constellation of symptoms. As clinicians, we're able to then use the DSM to support our diagnostic process, and it gives us a model or a framework for best practices in terms of treatment options, possible trajectories of the illness, research guidelines, and prevalence data. But here comes the but, and this is important. The DSM is not an exhaustive list. It doesn't contain every mental health disorder in existence. It contains only certain ones. It contains only certain criteria. And the criteria is based primarily on symptom presentation in the case studies that were used in its development, which tended to be mostly white men, white American men. And so this is a criticism that we hear a lot of the DSM, which is very valid, which is that it was essentially written by white men for white men. And while, of course, that's not strictly true, historically speaking, women, uh, BIPOC communities, um, children have all sort of been left out of consideration and not looked at as individual demographics that might need special consideration. The symptom presentation for most disorders is based on sort of a Western male perspective of culture, of behavior, and presentation. An example that I can think of is I remember hearing about mental health professionals from all over the world who were traveling to Rwanda after the genocide in order to be able to provide mental health services to the people who had survived that atrocity. And the Western-based mental health providers who were functioning in that DSM model and using traditional Western therapeutic models were sitting down to do talk therapy with these survivors who could not understand why they were being asked to sit down indoors to talk about something that had been traumatic for them. Their culture was not recognizing that sitting down indoors, isolated from other people, was going to be beneficial. And so being able to consider not just how cultural differences impact treatment, but also how cultural differences are going to impact symptom presentation is extremely important when we are doing an assessment of a patient who has come to us to determine their diagnosis. But to bring this back to our specific topic today, to say that kids can't have bipolar disorder because it's not in the DSM is simply false logic, and it is based on a flawed book. And I say flawed not to be excessively critical, but to simply acknowledge that it is not perfect and it doesn't contain everything that we need. So not every mental health condition is in the DSM. And if it's not in the DSM, it doesn't mean it doesn't exist. And if truth be told, the primary use of the DSM nowadays is not just to dictate diagnosis, but to provide mental health care professionals with the diagnostic codes they need in order to be reimbursed by insurance companies, which should give us pause when we treat it as an authoritative text. But again, another but, the DSM is what we have to work with. So we will work with it. We will start by taking a look at the criteria that is listed in the DSM for bipolar disorder in adults. And so many of you may be familiar with this, some of you may not. We'll go through it relatively quickly. The first criteria is that there is a distinct period of abnormally and persistently elevated and expansive or irritable mood. And that this usually involves increased goal-directed activity or energy lasting at least 1 week and present most of the day, nearly every day. Now, I want to say here, in children, lasting at least 1 week is rare because children often experience what is called rapid cycling or ultraradian cycling, where they can go through a mood episode or 2 or 3 or 4 within a single day. So this is our first clue that there's a presentation difference between children and adults. But this is our first criteria for a manic episode. The next criteria is that during this period of mood disturbance, there are noticeable changes from usual behavior that include things like increased self-esteem or grandiosity, increased talkativeness, pressured speech, distractibility, increased in goal-directed behaviors that could be psychomotor agitation or other types of increased goal direction. In order to more deeply understand these symptoms, we do need to consider how developmental stage and age impact the presentation of these symptoms. So for example, how might grandiosity look in a child versus in a teenager? versus an adult? How might sleep disturbances be experienced differently in childhood compared to adolescence or adulthood when circadian rhythms are different in all three stages and sleep needs are different in all three stages? How do we frame distractibility or inability to focus in children whose executive functioning skills have not developed to a point where they can always sustain long-term attention? How do we view energy and increased intensive focus or interest in children versus adults? How do we understand chronic irritability in children in relation to mania and hypomania? These are things that, generally speaking, our training programs don't examine, and we are going to be looking at in more depth today. So as we consider these questions, let's keep in mind all of those items that were just highlighted. In a bit, we will talk more deeply about this. Okay, criteria C. Criteria C. Mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, which we have to remember in children, their occupation is going to school and learning, or that it might necessitate hospitalization to prevent harm to self or others, or that there are some psychotic features. Criteria D, the episode could not be attributed to the physiological effects of a substance or to another medical condition. So now let's turn to depressive episodes. Again, let's pay attention to the highlighted criteria that I have here, which is depressed mood most of the day, nearly every day, and sleep disturbances. Again, we saw the sleep disturbances as part of the criteria for mania and hypomania. These symptoms often present in children and in teens as irritability, rigidity, and refusals to try new things or to deviate from their expected routine. These symptoms in children can appear oppositional, they can appear defiant in nature, and some would do call it manipulation. They say that children are being manipulative, but there's actually evidence when they become irritable, rigid, uh, oppositional, defiant, they are actually communicating to us that they are experiencing a symptom breakthrough that is involuntary. And that manipulative behavior is actually likely them just trying to get help to cope with those involuntary symptoms. It's difficult sometimes for us as adults to understand this because our perception is that children are supposed to follow instructions. But when kids have mood disorders, very often they are not able to follow instructions because of those involuntary symptoms. Additional symptoms of depression in children include feelings of hopelessness and worthlessness, shame or guilt that is inappropriate to the situation, and a decreased ability to concentrate or an increase in indecisiveness. In children and adolescents, difficulty concentrating and attention, this is often attributed to ADHD, attention deficit hyperactivity disorder, because it is considered to be the most commonly appearing developmental disorder of childhood. And it often manifests itself during the school day, through academic tasks, and in high demand environments. But when bipolar disorder is suspected, when a mood disorder in general is suspected, then we must rely on the advice provided by Dr. Charles Popper, lecturer at Harvard Medical School, McLean Hospital, where he tells us all the features of ADHD can be seen in mood disorders at the same time. So ADHD is a diagnosis reached only after ruling out a mood disorder. If you are interested in taking a deep dive into differentiating bipolar disorder and ADHD with us, please join us in August when we will be having a seminar differentiating bipolar and ADHD. But this is very important, and this is not what we are taught to do as clinicians, but it is best practices to rule out a mood disorder first before attempting to address the symptoms that we think might be ADHD, because the medication implications there are important and very, very different. But back to the criteria. Um, as we do in all diagnoses, this criteria is that we have to check to make sure, apologies, I skipped one, that the symptoms are causing clinically significant distress in all those areas of functioning, the same as we were examining in a manic episode, and that in C, we are doing what we do with all disorders and making sure that this episode is not attributable to the psychological or physiological effects of a substance or another medical condition. So let's take a moment to reflect on the bipolar diagnosis. There are currently listed two different types of bipolar disorder. Bipolar 1 can be diagnosed without a major depressive episode. Bipolar disorder 1 can be diagnosed solely on the basis of a documented manic episode. The assumption here is that if a manic episode has occurred, that at some time in the patient's life, a depressive episode will also occur. Bipolar disorder 2 is, let's just say it's not called 2 because it's less than bipolar 1, that it's not as serious, not as severe, not as important to treat. The difference between bipolar 1 and bipolar 2 is that in bipolar 2, there has been a depressive episode and that there has at least been a hypomanic episode. Some people with bipolar disorder can live with bipolar and never experience a full-blown manic episode. But what they are experiencing is hypomanic episodes, a reduced intensity manic episode. But it is still a very serious illness, and the individual typically has significant functional impairments. If you're interested in learning more about bipolar 2, I'd like to recommend that you check out our YouTube channel if you're not there already. We have a webinar that we conducted with author Sarah Schley. She is an adult who has bipolar 2. She has had it her whole life. She was in her 40s before she was accurately diagnosed and given effective treatment to treat her bipolar 2 disorder. And she's a wonderful, eloquent speaker on the lived experience and what we need to know as a community about the experience of having bipolar 2. Also, as an aside, I want to mention here that some professionals and parents have stated that their goal is to have a child who has bipolar 2 or bipolar 1 to sort of be controlled, have their symptoms controlled while they're in a mild hypomanic state. They believe that the mild hypomanic state keeps them focused, keeps them driven, gives them the ability to accomplish the tasks that they have to face at school and in daily life. But there are very serious concerns that go along with holding someone in a permanent state of mild hypomania. And one of those is the impact that it has on sleep. Sleep disruptions in bipolar disorder involve lots of health repercussions, including higher risks of heart disease, higher risk for stroke, higher risk for developing diabetes and kidney disease. Impulsivity that's experienced by individuals living with bipolar 2 who are in a hypomanic state can lead to potential social, academic, financial, and occupational difficulties. That impulsivity also is dangerous when we consider the self-harm and self-injurious behaviors that can emerge as symptoms of bipolar disorder. As we mentioned earlier, the sort of widespread critique of the DSM is that the symptoms of the disorders, not just bipolar, were written without regard to the way symptoms present in children and focus from a developmental standpoint on how symptoms typically present in adults. And so the language currently used to define major depressive episodes and manic or hypomanic episodes is incomplete. It doesn't accurately describe the experience that children and adolescents have when they live with bipolar disorder. So, what's missing in this shared common language that the DSM provides us is how to determine if a child or teen is experiencing the symptoms of bipolar disorder. And that is truly problematic because age, developmental stage, and observed symptoms are the essential factors that we use when we are determining whether or not the criteria leads to a particular diagnosis. So it is estimated that for the general population, it is conservative to consider that an individual's risk of having full-blown bipolar disorder is approximately 1%. Disorders on the bipolar spectrum can affect anywhere from 4 to 6% of the population and 3% of all children. 7% of children who are already receiving outpatient psychiatric care actually have bipolar disorder. Again, the numbers are higher for those who are inpatient. So if you are working in an inpatient facility, if you are working in outpatient psychiatric care for children, know that the likelihood that someone you are seeing has bipolar disorder is far greater than in the general population. Family history is extremely important here as well. When one parent has bipolar disorder, when biological parent has bipolar disorder, the risk to each of their children that they may develop bipolar is 15 to 30%. When both parents live with bipolar disorder, that risk that their children will develop bipolar disorder increases to 50 to 75%. So let's all think about that for just 1 second. By medical standards, having one parent with bipolar disorder would automatically characterize that person as being high risk. If there are two parents who are living with bipolar disorder, it is more likely than not that that child will also develop bipolar disorder at some point in their life. If a child had a 30% chance or greater of developing a serious illness like epilepsy, diabetes, or breast cancer, it is safe to assume that both parents, as well as their physical medical health care providers, would be on alert and would be routinely assessing for emerging symptoms. But as a field, we are not doing this with bipolar disorder, which suggests that even very well-educated and trained providers don't necessarily realize the necessity of completing a full family history, weighting it sufficiently in their assessments, and conducting routine ongoing assessments of that child for emerging symptoms of bipolar disorder. So to this point, it is estimated that up to 51% of individuals living with bipolar are not currently being treated for bipolar disorder. This means that about 3 million people per year are living with untreated bipolar disorder at any given time. NIMH, the National Institute for Mental Health, in 2022 noted that bipolar may be found in youth as often as it occurs in adults. And as we noted earlier, as reported in bipolar disorder statistics from the bipolar disorder statistics from the Depression and Bipolar Support Alliance, 1/3 of the 3.4 million children and adolescents diagnosed with depression in the United States may actually have early onset bipolar disorder. So, how can a child or adolescent be diagnosed appropriately or in a timely manner if the language we use to determine signs and symptoms of the illness primarily reflects that of adult symptom presentation? The truth is that it hampers the process by creating ambiguity over whether or not the child or adolescent is meeting the criteria for bipolar. And that ambiguity delays treatment and delays recovery. And we must consider that if we deny the existence of bipolar disorder in children, that treatment is delayed, and that treatment delayed is treatment denied. At the intersection of mental health and psychiatric law in the past few decades, we have seen a significant increase in attention to mental health jurisprudence and the preservation of human rights in the context of mental health care access and treatment. Authors of the December 2018 article titled "Treatment Delayed is Treatment Denied" in the Journal of the Academy of American in the Journal of the American Academy of Psychiatry and the Law states that of considerable consideration, however, are those cases in which rote procedural approaches produce unintended consequences for the very persons such maneuvers were designed to protect. Delays may ironically lead to an acute illness becoming chronic and to a single bout of inpatient services being transformed into a lifetime of revolving door psychiatric admissions. And it deprives patients of the liberation from illness that is the common goal of all stakeholders. This absolutely 100% applies to children and teens whose providers have decided out of hand ahead of time that they must have something other than bipolar disorder because it simply can't occur in kids. The stakes are too high for these kids. Statistics show us that 20 to 60% of the 6 million people living with bipolar disorder attempt to end their life, and that nearly 20% are successful and die by suicide. That is a lot of people at risk for death. There are also high stakes when it comes to bipolar disorder around substance abuse. Statistics show that with bipolar disorder 1, it has a lifetime prevalence rate of 40% for developing a substance abuse disorder. In bipolar 2, those lifetime prevalence rates are 20%. So imagine, again, a child that because of family history is known to have a 30% chance of developing bipolar, and as a result of that bipolar has a 40% chance of developing a substance abuse disorder. Now imagine that child is seeing a provider who says, nope, kids can't have bipolar, and they receive no treatment for the illness they are statistically most likely to have. Or worse, are given treatments for other disorders that they don't have that only make those bipolar disorder symptoms worse. We must be proactive in assessing and treating the signs and symptoms of bipolar disorder and its early onset, adjusting parenting strategies to match the child's needs as we teach in the palliative parenting classes that we offer, and to provide appropriate screenings and treatment for this disorder. So, the diagnostic process, therefore, must include a willingness to consider bipolar as a possibility, followed by an understanding of how symptoms of bipolar present in children and teens, how to use validated assessment measures to attempt to detect bipolar disorder beyond symptom report from parents, and how to conduct differential diagnosis. Hopefully, the material we've already presented here provides ample evidence for the position that bipolar disorder should at least be considered. So next, we're going to look at understanding those symptoms of bipolar disorder that are present in children and teens, our second learning objective. Prodromal or prodrome. When we talk about symptom presentation in childhood, the first thing we have to do is address the prodromal period, which can happen either quickly or slowly, depending upon the individual. And prodromal really means the period of time between the initial presentation of a symptom and the full-blown development of the illness. It is essentially the early signs of illness. And this period is extremely important because as the individual undergoes behavioral and cognitive changes that are associated with expected development, these symptoms of the illness are growing at the same time, and those growing symptoms can lead to psychosis. They are great risks for these kids are at great risk for misdiagnosis, having their symptoms minimized or dismissed, even being disciplined for the symptoms that they are presenting. When disciplining someone for an involuntary symptom will never, no matter what the illness, result in any meaningful change. For example, so one family that we worked with, the child was in the prodromal period that lasted for years and years, and the mother described the symptoms as appearing so gradually that they were always able to attribute it to something that was going on in the environment that the child was experiencing that made it feel as though this thing could be developmentally expected. She became so accustomed to her child's what she called quirky behaviors, sobbing, episodes of anxiety. No one thought they were strange as the child grew and they intensified. The symptom development was essentially the same thing as a slow boil, where eventually that pot had to bubble over in order for them to realize that something was in need of being addressed clinically. So what happens so slowly over time eventually becomes the norm and becomes the routine. The prodromal symptoms of bipolar disorder in children and teens include irritability, aggression, sleep disturbances, depression, erratic mood swings, manic and hypomanic symptoms, hyperactivity, anxiety, and that is the most common prodromal symptom, anxiety. This leads to the concept of misdiagnosis, which again, you can learn about through some of our other offerings. But this is why very often children who have been misdiagnosed actually have bipolar disorder. They have been misdiagnosed with anxiety. So it's easy to see when we're looking at this list how these symptoms could lead people to think of other diagnoses. Back in 1998, the book The Bipolar Child by Dimitri Popoulos and Janice Popoulos revolutionized our understanding of bipolar disorder in children and teens. It's still considered to be an authoritative text on the subject. It is currently in its third edition. I happen to personally love the subtitle, The Definitive and Reassuring Guide to Childhood's Most Misunderstood Disorder, because it speaks to the fear that parents have that there is no solution to what their child is facing. We just finished covering The Bipolar Child in our book club. Author Dimitri Popoulos was with us to talk about the book. It was a wonderful experience. If you have not read it, I highly recommend that you pick up a copy. You can support CMHRC by purchasing it from our book club page on our website, which will use our affiliate link. So you'll pay whatever it costs and we'll get 2 or 3 cents back, which every little bit helps. So this book documents the very common bipolar disorder symptoms that parents and children report, including some that we have already discussed. And they are grandiosity, impulsivity, hyperactivity, sleep disturbances, which include difficulty falling asleep, staying asleep, restless sleep, nightmares and night terrors, difficulty getting up in the morning. They experience distractibility, restlessness, fidgetiness, periods of low energy and withdrawal, also known as depression, and they feel easily humiliated or shamed. Additional very common symptoms include things ranging from rapid cycling, as I spoke about earlier, where 3, 4 different mood episodes are happening over the course of one day, to hallucinations, to rages, and temper outbursts. The category of common symptoms reported includes paranoia, suicidal ideation, self-injury, hypersexuality, fascination with gore and blood, as well as other symptoms. It's also worth pausing here for a moment to take a look at the symptom that is identified as manipulative behaviors. As I mentioned earlier, authority figures like to toss around the word manipulative when they're talking about a child who won't comply, or a teen who has his own mind about what it is that he or she wants to do. And so parents or other authority figures interpret these symptoms or behaviors because they're not the same thing. In some cases, it's a symptom. In some cases, it is a chosen behavior. But they characterize them all as deliberate. And one vice principal, actually, who was very frustrated with a child who happened to have bipolar disorder, told the parent that the 7-year-old was just trying to get out of trouble when the 7-year-old reported that he wanted to die. In reality, that child was experiencing a mood incongruent symptom episode. They were sad, they were hurting, and they wanted very much to die. But at the same time, they had the energy from the mixed mood state to make it happen. This mixed mood state, depressive, suicidal ideation symptoms co-occurring with the energy levels of a manic episode, are the most dangerous stage for anyone with bipolar disorder, children included. Now, luckily, in this case, the child's parent was educated about mood incongruent symptoms and understood that the child needed immediate psychiatric care and did not accept the in-school suspension that was recommended by school staff. This is really important. We hear all of the time the phrase, the child is just seeking attention. It is used in both heightened circumstances as well as less extreme ones. Often symptomatic and non-symptomatic children are characterized as being manipulative when they are in fact using the only tool available to them to express a need that they need to have met. Behaviors are a communication of need, not intent. And this is extremely important because we have to remember children lack agency. The younger the child, the less autonomy they have. They continue to have rules that are being externally imposed by others that may be in direct contradiction to the symptoms that they are experiencing. And so when they are behaving in a way that the adult feels to be disruptive, manipulative, counterproductive, what that child is saying to us, what that teen is saying to us is help. It is our duty as providers and as parents and as trusted grown-ups to respond, not with discipline, but with help. So these lists of symptoms that we've just gone over are comprised of things that are observable, things that we would call signs: bedwetting, binge eating, motor and vocal tics, cruelty to animals that can be observed, aggressive and violent behavior towards others. It's important to note these are less common symptoms of bipolar disorder. And the reason I point that out is it's important to remember that not everyone who has bipolar disorder is going to be aggressive or violent. If they are, it is not unexpected, but we should not meet someone who has bipolar disorder with the expectation that they will be aggressive or violent or cruel to animals. But we need to keep this in mind as we move through the diagnostic process. Another thing that's important to remember about this is that These are things that family members may keep hidden. They may not disclose to a provider in session because they are trying to protect their child. They don't want their child to be stigmatized. They don't want their child to be judged. They want the provider to like their child. And so they may be concerned that the child will be taken away from them through Child Protective Services investigations or committed to an inpatient facility against their wishes. So these are things that may be hidden by the families. It is important for us to be able to say, A, are they really that less common, or are they simply less reported? And also, we need to be able to ask about this when we are taking a history of the illness, and to ask without judgment so that our clients and their parents feel as though they are in a safe place to disclose this information. Now, how do we determine symptoms versus developmentally expected behaviors? For example, we'll start with grandiosity. Children are supposed to have an imagination. If a child says they're Superman, we assume they're pretending. We often encourage this pretend play. However, when a child with bipolar disorder says these things, they may actually believe it. I'm reminded of a family that shared with us that when their child was small, whenever this child would get into trouble, the child would say that they were going to call the President of the United States and tell them that they were being mistreated. And then the president would tell the parents that they had to stop being mean by not letting the child stay up late, stay up past their bedtime, eat their vegetables, whatever it was. As adults, we may be inclined to look at that and think, oh, that's cute. Oh, look at this precocious child. However, this child and many others genuinely believed that she was going to be able to do that because she was experiencing an episode of grandiosity. Parents report manic episodes that can include them hanging on to the back of their child's clothing as that child is trying to jump out of a second-story window to fly like Superman because they genuinely believe that they can. That type of grandiosity hopefully can be caught before the child is climbing out the window or jumping off the roof because they believe they can fly. But when it gets to that point, hospitalizations are very often required. Imagination is also something we are quick to attribute for hallucinations and delusions. If a child reports hearing the voice of another child, it could be interpreted as them having an imaginary friend. The belief that my teacher hates me or no one likes me can be attributed to a child exaggerating or not having enough perspective to understand that when they are a limit is set or a discipline is put into place, that it is not a characterological slight against them. But too often with bipolar disorder, these experiences are actually hallucinations. They are actually delusions. And we have to be able to look in not at what we are viewing, but getting information about what the subjective experience of the child is. And are they actually hearing that voice, or do they know that what they are talking about is an imaginary friend? Now, hyperactivity. Let's think about a child being full of energy, sometimes silly, goofy, exuberantly happy, and we could observe, wow, that kid is super active, right? But determining, again, the subjective experience, what is motivating that high level of energy is really important. One psychiatrist who worked with children and adolescents shared his clinical observation of the difference between hyperactivity and mania, and that it can be felt by the clinician. With hyperactivity, we observe how busy the child is. With mood disorders like bipolar disorder, the child's increased energy can actually be felt by the clinician, and the reaction may be, wow, this kid exhausts me. It's an important but subtle difference. Sleep difficulties are also noted in the DSM for adults, and many children with bipolar disorder have difficulty falling asleep, difficulty staying asleep, difficulty waking up in the morning. And other children may not have obvious sleep disturbances, but further investigation by sleep medicine doctors can unearth disruptions in sleep cycles, particularly in the crucial REM phases of sleep. Um, if you are interested in collecting information on your child's REM sleep quality and duration every night beyond just looking at them to see if they're asleep, we highly recommend a product called from the company Withings. We have no connection to them. There's no kickbacks unless you, again, use one of our affiliate links, but we're not affiliated with Withings. But they have a product called the Sleep. It is a mat that goes between the mattress and the box spring, and the child simply sleeps at night on top of that mat, and they don't feel it because it's under the mattress. And that mat will give you real-time data on how they're sleeping, their sleep quality, their REM duration, et cetera, et cetera. And so some parents may not think it's odd that their child is getting only 6 or 7 hours of sleep a night, or they may simply not be aware of the fact that their child is not getting the necessary quality of sleep. We've had families who've said to us, no, our kid sleeps great. We can see that they're sleeping. And then they get the mat and they plug it in and they get that data on their phone and they say, holy cow, I had no idea this child was not getting any restorative sleep. So it's a good thing to check out. Additionally, children with bipolar disorder often experience parasomnias, one of which is graphic and gory nightmares. And unlike the rest of us who wake up before the gruesome completion of a nightmare, these kids, they don't wake up until after the horrific, deadly end takes place. And so when this trauma occurs at night while they're sleeping, it can have impacts during their waking life where the imagery from this nightmare is intruding on their waking life involuntarily. Now, when these nightmare experiences happen as night terrors, the child may not remember that they experienced this at all consciously, but they may be prone to drawing or talking about gore, talking or drawing about violence. And this should be understood as a process the child is going through in order to understand and integrate into their waking life what is occurring, the trauma that is occurring to them in their sleep. Now, sleep difficulties are noted, apologies. As clinicians, we understand what hypersexuality looks like in adults or in someone who is post-pubescent. But what about a 6-year-old? Sometimes hypersexuality can look like excessive touching or petting someone else's hair, shoulders, back. They may feel a strong need to sit very close to a special someone over and over and over again. Kids say things like, show me your butt. Kids say things like, prove to me that you're a girl. Show me your privates. Again, we may be inclined to dismiss some of this as precociousness of childhood or as harmless behaviors and attempts to connect, but it can actually truly be hypersexuality that is manifesting itself in someone who is not post-pubescent and doesn't have certain physical capacities in order to engage in other hypersexualized behaviors. Children with hypersexuality as part of bipolar disorder may refuse to wear clothing, walk around naked, change without their bedroom door closed or without their bathroom door closed. They may ask to see other people undressed or spend prolonged periods of time staring at and touching their own body while naked. I want to stress that these, for the most part, are developmentally expected behaviors, and that as children grow, they are naturally curious about their bodies and the bodies of other people. And we are not attempting to shame that child or their family for their interest in their own bodies or others. Not at all. And we also want to point out that clinicians may be inclined to view hypersexualized behaviors as evidence of some sort of abuse that has taken place. And so we must do our due diligence to determine whether or not the child has been exposed to sexually abusive content or sexually abusive predators in their environment. But it is also essential to remember that with hypersexuality and bipolar disorder, exposure to sexual abuse is not a prerequisite for the intense sexual drive that can be seen during a bipolar mood episode. So yes, we do our due diligence, but we recognize that just because we're seeing sexualized behavior does not automatically mean abuse took place. In the DSM, rapid cycling is defined as 4 or more mood episodes per year. In children, researchers associated with the Juvenile Bipolar Research Foundation have found that children can cycle as many as 4 times in a single day. This is currently called ultraradian cycling, and parents often describe these episodes as meltdowns, rages, tantrums that are inconsistent with age and are inconsistent with the situation, and that these meltdowns can last extended periods of time, up to 45 minutes, 60 minutes, 90, 120 minutes. In school, these rapid cycling episodes are often referred to as being disruptive or violent, and they're described as being willful and intentional behaviors. Children with bipolar disorder will later feel great remorse, shame, and guilt, and they may also sometimes be legitimately unaware and unable to remember the aggression and damage that they did during these symptomatic episodes. As we mentioned, the DSM lists bipolar 1 and bipolar 2 as different types of disorders. And in 2006, the Juvenile Bipolar Research Foundation researchers identified a new phenotype of bipolar disorder, which they dubbed fear of harm, or FOH, out of deference to the most prevalent symptom that they were uncovering, which was intense, extreme, exaggerated, debilitating fears. In the last 20 years or so, it has undergone a number of name changes and is currently referred to by providers as thermoregulatory sleep dysregulation disorder. I believe our clinical seminar next month in April is exclusively on TSDD, and where we will take a deep dive. But for now, we're just going to sort of go over the fact that in the field of mental health, FOH is unique in that it is the only mental illness at this time that has a known biological marker, and that is an inability for the body and the brain to correctly regulate body temperature throughout the day and night. And researchers estimate that roughly 1/3 of all people with bipolar disorder have this specific phenotype and may have fear of harm. This date, I will say, is not correct. I do believe it is in April, but we will get to that in a bit. All right, so now on to our third learning objective, recommendations regarding the diagnostic process. Dr. David Miklovitz, the author of the Bipolar Survival Guide and the new book that he just had come out last October, Living Well with Bipolar Disorder, that actually will be our April book club offering. We meet on the third Thursday of each month, and in April we will be discussing Living Well with Bipolar Disorder, and Dr. Miklovitz will be there with us. So if you would like to participate, please go to our website's book club page, and you can sign up to be a part of that book club to meet Dr. Miklovitz and to talk with him about his book. So in Dr. Miklovitz's book, The Bipolar Survival Guide, he talks about what the gold standard assessment is for bipolar disorder. And this includes a comprehensive biopsychosocial assessment of the child and capturing of the family history. It involves a review of all medical records, going back to birth, and all previous assessments. It involves the use of standardized, proven assessment tools, in-depth interviews with parents and caregivers. And he also describes the need for families and caregivers to work together to become detectives and to document concerns, symptoms, observations. Our toolkit app is designed to do exactly this and to allow real-time, non-intrusive communication between parents and patients and their providers. And to remember that kids go through a prodromal phase where it can be difficult to distinguish symptoms from normal development or other medical issues. But he notes that very few places around the country operate using this gold standard approach. Having an extensive family history, doing a couple of hours worth of clinical interviews with family and caregivers to get details on symptom presentation, to look at all medical records going back to birth, to look at all school records, to look at all previous assessments done by assessing psychologists, psychiatrists, occupational therapists, speech therapists, pediatricians, teachers, anyone. It is essential in order to be clinical detectives, but it does take a tremendous amount of time. We also have to coordinate with other disciplines to rule out medical conditions. We have to work with their medical provider to figure out if there are hormonal or metabolic disorders. Are there infectious diseases, neurological disorders, blood disorders? I mean, the list goes on of all of these things that we have to be able to rule out before we can successfully make a diagnosis of bipolar disorder. And it is extremely important to have that cross-disciplinary team working in order to consider all possible diagnoses while keeping in mind that more than one condition can occur at the same time. Can sound overwhelming. Honestly, it can be, but there are measures that we have that can help. One thing that we do in our professional discussion groups, as I mentioned earlier, is we bring together interdisciplinary teams of providers so that we can case conference with anonymous cases from our current caseloads to help us figure out, are we diagnosing correctly? Is bipolar present or not? And if it is, what do we do about it? So we're going to start with an assessment tool that you can use in your practice. It is easily available online. It is developed by Dimitri Popoulos and his team at the Juvenile Bipolar Research Foundation. We do not have anything to do with the fees that they charge to score it. We are advocating for it because we truly believe in the value of this and their other measurement. So the first is the Child Bipolar Questionnaire, as well as the Janie and Jeffrey Illustrated Interview for Children. Now, the Child Bipolar Questionnaire provides a reliable source of information about the presence of early onset bipolar disorder. It is simple to use. It has proven data from close to 2,000 children who were either diagnosed with or at risk for bipolar disorder. And this 65 question test collects information not only on the symptoms of bipolar disorder, but also on symptoms of other disorders that often co-occur at the same time, such as mania, major depression, separation anxiety, generalized anxiety disorder, and more. But the CBQ doesn't only ask if the symptoms are present. The CBQ asks for those experiences to be reported on a Likert scale of how significant and severe they are. So each question's response is rated on that Likert scale based on the frequency of occurrence, with 1 for never, 2 for sometimes, 3 for often, and 4 for almost constantly. The CBQ and its scoring system have been rigorously tested and has been shown to be extremely valid and reliable. The CBQ can identify with a 96% accuracy the presence of bipolar disorder. And best of all, the CBQ requires less than 20 minutes to fill out. It can be completed at home by parents and caregivers without the need for a professional to administer it. And the professional can get a copy of the results that show not only the answers given, but the relation that those scores have to the scoring algorithm and an overall likelihood in the end that the child does or does not have bipolar disorder. The second testing tool that I mentioned is called the Janie and Jeffrey Illustrated Interview for Children, and it's a companion to the CBQ that is completed by the child. In fact, it is the first assessment for bipolar disorder that was ever designed specifically for the child to take. And the JJ has comic strip style illustrations that engage the child's interest, making them feel comfortable and safe to answer questions that are in a way that is honest. Each question is illustrated with pictures that are designed to capture the essence of what that symptom is, and allows the child to relate to it without having to use words. Through the responses that the child gives, again, because it is on a Likert scale of never or hardly ever, sometimes very often or almost constantly, we get an insight into the child's actual experience of the world. And being able to share that makes the child feel less isolated and less alone. And it encourages the child to talk about things that they might not otherwise feel comfortable, including mood disruptions, fears, hallucinations, or suicidal thoughts. Most importantly, again, as I mentioned, JJ uses this Likert scale that gives this information on how the child experiences it at each symptom. And like the CBQ, it's quick. The JJ takes about 15 minutes for the child to complete on their own. So using these proven and validated measurements and assessments and conducting a complete history is recommended by Dr. Miklovitz and others who advocate for this gold standard approach, and it can go a long way to clarifying accurate diagnoses. But we do acknowledge that the symptoms of bipolar often overlap with co-occurring disorders that are seen in childhood. And the term that we use to describe this is alphabet soup. When parents describe to us all of the various diagnoses that they received before arriving at a correct diagnosis of bipolar disorder, they have, as I mentioned earlier, usually spent about 10 years trying to find it. And when they come to us for help, they're usually at the end of this journey, and all of these things, plus others, have been given incorrectly. And so one mother in our community actually described this experience of a provider who kept trying to, and the word she used was shoehorn her child into an ODD diagnosis, despite the fact that he didn't exhibit all of the symptoms. The mother was persistent, pushed back, said, no, that doesn't apply. No, that doesn't apply. And eventually found a new provider who was able to give an accurate diagnosis that included bipolar disorder. So part of the importance of doing a differential diagnosis is to ensure that we're considering every aspect of the symptoms that are presented in order to rule them in or out, and not just to go looking for bipolar disorder. But we have to take into consideration a pretty extensive set of steps that we need to go through in order to do this differential diagnosis. And I want to provide two examples. The first is bipolar versus ADHD, which is very, very often confused. The neurological factors that can be used to differentiate ADHD from bipolar disorder include things like reaction time, processing speed, and motor preparedness. These are things that any testing psychologist is very familiar with, can look at and compare the information on how these things are impacted by mood disorders such as bipolar and how they are impacted by ADHD. They are not the same. Dr. Charles Popper, again from Harvard Medical School, McLean Hospital, has a paper where he lists 15 characteristics to differentiate between bipolar and ADHD. And he says that all of the features of ADHD, as we said before, say it again, say it so many times, can be seen in mood disorders. So ADHD is a diagnosis reached only after ruling out a mood disorder. If you're interested in taking a deep dive on this with us, again, we're doing a clinical seminar in August exclusively on differentiating bipolar and ADHD. Our next example is DMDD. To be a little cheeky, we're not doing a full clinical seminar on differentiating bipolar and DMDD because it is so incredibly simple. There's so much consternation in the field about it, but it really is quite simple, and the information is right in the DSM. Criteria I for disruptive mood dysregulation disorder states there has never been a period lasting more than 1 day during which the full symptom criteria except duration for a manic or hypomanic episode have been met. Also, in the notation of criteria J, it states clearly, if an individual has ever experienced a manic or hypomanic episode, the diagnosis of disruptive mood dysregulation disorder should not be assigned. The problem that we face here, the bottleneck around DMDD, is not whether or not it is difficult to differentiate from bipolar. The bottleneck is practitioners who don't know what a manic episode in a child looks like. And so when we look back at the symptoms that we explained, these are some of the ways that it appears. It appears as irritability. This is what grandiosity looks like. This is what hypersexuality looks like. It becomes much easier to realize that, oh, a manic episode occurred. Therefore, DMDD does not apply. When we're doing the differential diagnosis, we have to have a process and room for support. And so again, we are reviewing all diagnoses that contain the presenting symptoms. We are investigating the triggers, antecedents, and precursors to symptom episodes. We investigate post-episode attitudes, feelings, cognitions. We consider all relevant family history, medical, educational, and developmental history on the child. We understand previous treatment attempts and their effectiveness or ineffectiveness. That specifically includes not only talk therapy, but medications. We consult with other providers, including pediatricians, occupational therapists, speech and language pathologists, family members, and friends. And we review with peers for diagnostic consultation. Now, there are going to be additional considerations when diagnosing a child with bipolar disorder. There is worry about stigmatizing the child with a serious mental illness for the rest of their life, starting at such a young age. There's a concern regarding the long-term effects of psychiatric medications. And there are concerns that pharmaceutical companies are heavily marketing what might be considered unnecessary medications. And the truth is, these considerations are enough oftentimes to make providers balk at giving the bipolar diagnosis, even when it is correct. And in fact, these concerns were so explosive in the late 90s that a man named Stuart Kaplan wrote a book opposing the diagnosis of bipolar in childhood and claiming that these children's symptoms were more likely accounted for by ADHD or ODD. And so he encouraged the use of stimulants, advocated for firmer parenting, which is really just a form of parent and child blaming and shaming. And he noted that the potential dangerous side effects for medications and their over-marketing of them to families. However, the ensuing reluctance to use proven mood stabilizers with children, which are the gold standard for bipolar disorder treatment, and instead using SSRIs and stimulants, has had a significantly detrimental long-term effects on children who are living with bipolar disorder. These stimulant and SSRI medications cause increased hospitalizations. They can induce mania and psychosis. They can induce aggression. They can damage your relationships with your children, with your clients, and with all the relationships that those children attempt to engage in their family and in their community. It is really important to note that one of the red flags for bipolar disorder in children is the use of an SSRI or stimulant that results in increased agitation, that results in aggressive behavior, that results in increased anxiety and energy. Many times providers see that and think, oh, well, the medication's just not at a high enough dose. But we know clinically speaking that when a child has an adverse reaction to an SSRI or to a stimulant medication, or even some of the non-stimulant medications for ADHD, that is a red flag for bipolar disorder and that a new investigation needs to be done. From a learning perspective, these stimulant and SSRI medications can cause children to lose days of learning, experience being disciplined for their disability, and fundamentally be denied access to a free and appropriate public education. In addition to stimulants and SSRIs, the antipsychotic medications that are often prescribed, such as epiprazole, risperidone. These are used as a quick first attempt to manage rapid mood shifts, including aggression and decreased ability to concentrate, et cetera, et cetera. But they have very serious consequences. And Dr. Papalos has explained to us in previous seminars that the literature in peer-reviewed journals does not support the idea that antipsychotic medications have long-term stabilizing effects. They may be able to stabilize a mood during an acute episode, which is why he recommends using them as PRNs or emergency meds that are not taken consistently, but only during acute crises moments in order to bring the child back to baseline, but that the use of proven mood stabilizers is the gold standard for bipolar disorder treatment. Antipsychotic medications contribute significantly to weight gain, to the development of fatty liver, to changes in metabolism, and elevated risk for developing type 2 diabetes in childhood. Every year there are newer antipsychotic medications made and marketed to assist with mood concerns, but the reluctance to use mood stabilizers in favor of using antipsychotic medications is misplaced because in the long run, children are being prescribed heavily marketed medications that have their own potentially serious side effects, do not demonstrate long-term mood stabilizing effects, and they are already living with the stigma that comes from having bipolar disorder, and not addressing it properly does not do that child any favors. So last, we are on understanding effective treatment interventions. We always talk about effective treatment being like a three-legged stool. There's medication, there's therapy, and there are lifestyle interventions. Medication. I want to reiterate, not every family is comfortable giving their child medication. Not every prescriber is comfortable writing scripts for children to have medications. However, what we do know, and that is an individual choice, but what we do know is that that choice has to be made with the truly informed consent. And so patients and parents need to understand what the potential benefits of those medications are, what the potential side effects are, and to make a decision informed about whether or not they want to proceed. That said, medication is most often a necessary component of bipolar disorder treatment, and very often it must be multiple medications working in combination with one another in order to achieve the desired results. So We know that medications need to be affordable. They need to be accessible in order for families to be able to take advantage of the benefits, and that multi-medication combinations are often necessary. Monotherapy is not common in the treatment of bipolar disorder. The gold standard, as I mentioned, are mood stabilizers. The gold standard, top one, is lithium. This is a safe and well-tolerated medication. The other two that can be used are lamotrigine and oxcarbazepine, depending upon whether that individual trends towards mania or depression in their symptom manifestation. You can get more information on this from our clinical seminar that we had with Dr. Papalos last year on our YouTube channel, where he talks about treatments for the FOH phenotype, and he talks about the importance of mood stabilizers as opposed to the use of antipsychotic medications. Other essential parts of the treatment plan include psychotherapy with a psychotherapist who is experienced in working with children who have mood disorders and can recognize those symptoms in children. We look to differentiate symptoms from behaviors. We focus on rapport building, not skill development. We know when to use traditional therapeutic interventions, and we engage family therapy and individual therapy for parents and siblings as well, because we have to recognize that therapeutic support and guidance is necessary for the family when we are treating a child with bipolar disorder. When we treat a child with bipolar disorder, we are actually treating the whole family. Lifestyle interventions are also essential in treating bipolar disorder. These interventions can include things like light therapy, circadian rhythm resets, cooling strategies, and diet and metabolic interventions like ketogenic therapy. We are having a seminar later this year on the light therapy and cooling strategies and circadian rhythm resets necessary in treating bipolar disorder. You can look for that on our website and on our social media pages. And later we will be, as I mentioned earlier, expanding our research study in metabolic therapies to be available to the general public. It is also, of course, important to consider the necessity of including things like diet and exercise to keep the body healthy, and to make sure that there is other intellectual invigorating activities and enjoyment in the individual's life. Life with bipolar is not about only getting treatment. It's about getting treatment so that we can experience the full range of enjoyment in life while remaining stable. We also find that it is extremely important in treatment to partner with schools. As I said earlier, occupational settings for children are school. And so treatment providers need to pair with schools often to ensure that the child is getting what they need in that environment. These include advocating for parents to have for the child to have accommodations and modifications, an understanding that their capacity fluctuates from day to day as well as seasonally, that IEP and 504 plans are both necessary for children who have these mood disorders like bipolar, and that they have the right to access their free and appropriate public education. We use the term, when we talk about parents who have to go in and have to fight for all of these accommodations for their children, the term we use to describe them is parent professionals. This is a term we use because parents have to make themselves extremely knowledgeable about bipolar disorder and their other mood disorders if their children have them, in order to ensure that their children can get the accommodations and treatments that they need. Parents make themselves aware of symptoms and diagnoses and interventions and what a mixed mood episode looks like and what treatment options are. And they do that when they are lucky. They do that in combination with us, the knowledgeable clinician who is there to work with them and to empower them to be that parent professional. Parents are the expert in their children. I cannot stress that enough. Parents are the experts in their children. And so parents need to be educated. Parents need to be given the opportunity to ask questions. Parents need to feel as though they are equal partners with their medical and mental health care providers and with their school in order to ensure their needs are met and that they are able to live a life high in quality and with stability. As experts on as experts on the disorders, we as professionals need to partner with parents to listen to them, to understand them, to believe them when they give us their interpretations and accounts, because they live with their child 24 hours a day, 7 days a week, and parents know what they're talking about. As I mentioned, we do have a toolkit for tracking symptoms, and I'm just going to very briefly explain what it does, because we all know the old adage that whatever happens, whatever we talk about in a session is usually what happened on the car ride over. A lot of us do telehealth now. We're not doing the car ride over, so we're going to hear whatever happened within the last 15 minutes, and that's going to seem like the entirety of the individual's experience when it's not. So what we have done is we've developed a toolkit that is a web-based app which is exclusively for parents to use. I shouldn't say exclusively. It was designed with parents in mind to track the features of mood disorders, bipolar disorder, FOH, other mental health disorders. It is a simple program that takes about 45 seconds a day to complete. It allows you to track daily symptoms, daily medication compliance. You're allowed to put in a narrative summary of the day. You can even include your local weather, and you are able to document diagnoses given, medication trials, the effects of various treatment interventions. And it allows you to graph and get data visualizations, including our symptom severity index score, that quickly gives the family a handle on triggers, medication compliance, and can allow you to see in real time, is the medication we prescribed having the intended effect on the symptom that we intended it to influence or not? And the reason that we tell providers about this is because with a provider account, you can have access to your client's data. And I have to tell you, we use this in our research study. Our researchers are able to access toolkit data for every single subject in the study in real time. And so at any moment, we can look and see, how is this person's symptoms today? Are they compliant with their medications? What's changing in their behaviors? What's changing in their environment? And it is an absolutely invaluable tool. So I highly recommend providers look into getting an account for yourself. Your patients, if you refer them, will get a discount on their subscription, and we don't upcharge you. You can have 1 or 30 clients on it, and it's going to be the same low price of $14.99 a month for you to have access to all of these tools. A lot of people think that bipolar disorder is unmanageable. And a lot of parents and adults who were diagnosed as children come back to us and say the one thing they wanted to know more than anything else when they were first diagnosed was that it is manageable. They wish somebody would have said to them, you or your child are going to have a great quality of life. You're going to experience joy and contentment and peace and satisfaction, and that it is essential to have hope. No matter how challenging the symptoms are, there is always hope. And studies show us that the more hope a person has, the more positive their outcomes are, that there is a correlation between a belief that a positive outcome will occur and the manifestation of achieving that positive outcome. It's also important to remember that the hope a family feels comes in part from the relationship that they have with us, their providers. And so when we work with families living with childhood onset bipolar disorder or other mood disorders or FOH, we're their guide on this journey. And with our knowledge, with your expertise, with the compassion that we all show, we can help them walk the path to recovery in a way that is consistent, respectful, and based on honesty and community. There are additional resources that folks can tap into. There's The Bipolar Child by Dimitri Pavlos and Janice Pavlos. There is uh, our resources at CMHRC, our toolkit. We also have a book that we've published that you can find on Amazon called Bipolar Disorder in Childhood. There's the National Alliance on Mental Illness, the Youth Mental Health Project, International Bipolar Foundation, and the Depression and Bipolar Support Alliance. We also, as I mentioned, have professional discussion groups. They last for 6 months each year from April to September. They meet for one 90-minute session per month. They are the second Tuesday of each month. It is $129 for the full series. You can register on our website, and we welcome occupational therapists, speech therapists, school nurses, nurse practitioners, psychiatrists, social workers, LMFTs, licensed counselors, you name it. If you work with kids, you are a part of an interdisciplinary team, and we welcome you to join us for our professional discussion group on bipolar disorder in children and teens. You can register for that on our website. It will be starting the second Tuesday in April, which I believe is the 8th. We also have upcoming free webinars and clinical seminars, including next month's What is Fear of Harm, August Differentiating Bipolar and ADHD, and in September we will have a webinar on understanding misdiagnosis in children and a clinical seminar on differentiating mood disorders and trauma in children. You can sign up for these on our website, cmhrc.org, under the free resources tab. New seminars and webinars are posted quarterly, so you can see what's coming up in the next few months, and we look forward to having you there. These slides include the works cited during this presentation. If you would like a copy of this slideshow, please look to your email that you will receive tomorrow from Zoom, where there will be a link that you can use in order to request a copy of the slideshow. And that is our full presentation. We're going to switch to Q&A session now, and so the recording will end so people can feel free to share their experiences freely. If you would like to participate in one of our Q&A sessions in the future, please make sure that you attend our live sessions. Thank you all for being with us, and have a great night.